You put your both. Okay. Yeah, that looks good. Okay.
Excellent.
Ready.
Good afternoon and welcome to the first of a series of CPD accredited webinars on the different childhood cancers. My name is Audrey Ludick and I'm the Program Development Manager for CHOC Childhood Cancer Foundation in South Africa. It is CHOC's mission to support children and teens with cancer or life-threatening blood disorder and their families, improving early detection and facilitating effective treatment. CHOC offers comprehensive child and families support through psychosocial, emotional, and practical support as we augment the different medical fraternities. Every time a child is diagnosed with cancer, it is a life-threatening or life-changing journey for the parents and the families. Childhood cancer is preventable. It's not preventable, but it is curable. The DJ at the World Health Organization said that too many children have their lives cut short by cancer. The survival rate in poor countries are scandalously lower than those in wealthy countries. In September 2018, the WHO launched the GICC, the Global Initiative for Childhood Cancer, with a goal of reaching at least 60% survival rate for children with cancer by 2030. If successfully implemented, approximately 1 million additional children with cancer can be saved in the next decade. As part of CHOC's awareness training and education program, we will be hosting monthly CPD accredited talks on different childhood cancers and the early warning signs thereof. We believe that early detection saves lives. We want to thank the members of the SACCSG who voluntarily give their time in support of these webinars. These webinars on childhood cancers are to increase disease knowledge of healthcare professionals, and in doing so, we hope to reduce the mortality and morbidity of children with cancer. Professor Janet Poole is today going to host our webinar on Wilms tumor. She is Prof Janet Poole, qualified as medical doctor from the University of the Witwatersrand. She then specialized in pediatrics and began her pediatric hematology and oncology career at the Johannesburg Hospital, today the Charlotte Macheke Johannesburg Academic Hospital. She then moved to Chris Hani Baragwanath as head of pediatric hematology and oncology. And after she became the principal specialist, she moved back to Charlotte Macheke Johannesburg Academic Hospital as head of pediatric hematology and oncology. She is also registered as a subspecialist in oncology. She is currently retired from government service, but gladly continues to practice pediatric oncology in private. We can't lose her expertise in pediatric oncology. She holds an esteemed position as Professor of Health Science and is an active member on several childhood cancer bodies and serves on the CHOC board. She has many collaborative publications on clinical research, and she's passionately, actively promoting the early warning signs of childhood cancer. One of Prof Poole's special interest and expertise is on Wilms tumor. Please welcome Prof Poole as she will present on Wilms tumor. You can put your questions in the chat and Prof will address these during the Q&A session. Prof, welcome and thank you. Over to you.
Good afternoon, everyone. I'm just going to share my screen. Okay, so today I'm going to talk about Wilms tumor. There are some basic facts, and there's just an update on the treatment of Wilms tumor in 2022. So Wilms tumor or nephroblastoma is a cancer that typically occurs in children and very rarely in adults. The name is referring to Dr. Max Wilms, the German surgeon who first described this tumor in 1899. And Wilms tumor is the most common form of kidney cancer in children. It's also called a nephroblastoma, nephro meaning kidney, and blastoma is a tumor made of embryonic tissue that is not yet fully developed. So nephroblastoma actually looks like what the embryonic kidney looked like in the embryo. So normally Wilms tumor accounts for about 6 to 7% of all childhood cancer and has a female predominance, but it definitely has a higher incidence in children of African origin. In South Africa in 2020, according to the South African Children's Cancer Study Group Registry, Wilms tumor was the second highest malignancy, accounting for almost 12% of all childhood malignancies behind leukemia. And this is quite significant, as normally brain tumors are the second highest cancer in children. So Wilms tumor accounts for about 85 to 90% of all renal tumors in childhood. And as you can see, the most of these are Wilms tumors, and then there's a small percentage of non-Wilms tumor, 10 to 15% of other tumors that occur in the kidney. Clear cell sarcoma and malignant rhabdoid tumors are the malignant, and then you have the congenital mesoblastic nephroma, which usually occurs under the age of 1 year. So there are no proven environmental risk factors, and it's usually sporadic. And obviously there's an ethnic variation in incidence rates. So it's higher in the African American and African populations, but lower in the Japanese population, for instance. The genetic predisposition is well documented and very complex. So in about 1 to 2% of cases, there are families which have more than one child who develops Wilm tumor, and this is the familial Wilms tumor. Unfortunately, this is not very common. There are more than 100 syndromes associated with Wilms tumor, which is about 12 to 15% of cases. But the two most commonest syndromes that we see the most of are Wilms tumor associated with a genitourinary malformation, such as a horseshoe kidney, hypospadias, undescended testes. And normally these tumors are positive for the WT1 gene. Then we also have Wilms tumor and hemihypertrophy, which accounts for about 3%. And then there's some others like the Beckwith-Wiedemann syndrome, which is an overgrowth syndrome, and the Dennis-Strash syndrome, which is renal disease and pseudohermaphroditism. Now, the story of the treatment of Wilms tumor is one of the successes in pediatric oncology. And so from the early 1900s, when only surgery could be performed, and at very, very risky times because of no anesthetics, because of non-aseptic techniques, the improvement obviously in the early years was due to improved surgery. However, after about 1965, when radiation and chemotherapy were introduced to treat Wilms tumor, did the survival rate then increase, and now sits at about 95% overall. And especially with the advent of the National Wilm Tumor Study Group, which was mainly in the USA, and the CHOC study group, which is in Europe, actually started in France. So improvement is obviously multifactorial, and the important thing is to identify the bad actors early. So we need to improve the understanding of biology and etiology. And this is one of the focuses of research today in Wilms tumor. We need to refine the use of the known clinical risk factors, which is the patient age, the tumor size, the tumor burden, and then the definition of metastatic disease and response to therapy. And a prognostic factor can only be evaluated in context of the tumor, of the patient and the tumor and the treatment that is given. And just to note that Wilms tumor is not curable if a complete resection cannot be performed. So surgeons play an important role in the treatment of Wilms tumor. The focus should be to get it right first time, and not to bungle along from the beginning. And then we can learn from international comparisons. So what are the hindrances to early diagnoses? So a lot of childhood cancer sometimes goes undiagnosed and untreated. This is due to a variety of reasons, especially in places like South Africa, which we are defined as a low middle income country. There's a lack of specialized medical services in a large part of the country. And then there are geographic distances from where they live, where the children live, to get treatment. There's also quite a lack of awareness in the health profession itself, from the primary healthcare sisters to doctors. And then obviously there are myths and beliefs about childhood cancer in the African population and in some other populations as well. So during 1999, the South African Children's Cancer Study Group came together and compiled the St. Silouan warning signs of cancer in children. And this has been adopted by the Department of Health in South Africa, and it was also adopted in 2000 in Amsterdam at the meeting of the Society of Pediatric Oncology, SIOP. And St. Silouan, the Silouan is actually used as a mnemonic for the early warning signs. So this is what, so CHOC is actually very active in looking at early warning signs and promoting them and educating primary healthcare workers, doctors, and many other people. And so this is a poster, which is also available in Afrikaans and a few other African languages. And obviously Silouan is like a mnemonic, and each letter stands for one of the warning signs in childhood cancer. And so obviously in Wilm's tumor, we are looking at L, which is a lump somewhere in the abdomen. So this is just a more expressed Silouan warning signs. And you can see that lump can be anywhere in the body, but we are going to concentrate on the abdomen or the tummy. So the examination of a pediatric abdomen is extremely important. And what I usually teach the students is that every child who comes to the clinic or the emergency department for whatever reason needs to have their abdomens just mildly palpated to actually see if there's anything there or not, because in a certain percentage of cases a renal mass is incidentally found and is totally asymptomatic, and then it would be quite small and very easy to treat. And so whether the child comes through an upper respiratory tract infection or a foreign body in the nose or ear or whatever, somebody should actually just feel the child's tummy, and it will take about 30 seconds to do that. You need to get a history about the time the mass has been present and the rapidity of growth and the symptoms. And abdominal pain in Wilm's tumor is not present until very late. Abdominal pain is not one of the first signs or symptoms. You need to undress the patient and look for genetic abnormalities like the hemihypertrophy. You need to then palpate the abdomen from the pelvis towards the chest and describe the location, the size, the consistency, whether or not there's also free fluid or ascites in the abdomen, and whether there's venous congestion, which would denote inferior vena cava blockage. So the most common presenting sign and symptom is an incidental or bulge in the tummy noted by the parents. Occasionally there is abdominal pain, which usually occurs after trauma, and this causes a bleed into the tumor or rarely rupture. So preoperative rupture is quite rare, but it can occur. It used to be said that the sun never set on a Wilm's tumor, and the surgeons used to go in and treat and resect the minute the child came in. However, that's not the case at the moment, and it's unlikely that the tumor will rupture unless there has been some predisposition to that. Hypertension or high blood pressure is seen in 25% of cases. And hematuria may be macroscopic or microscopic. Sorry, and this may lead to iron deficiency anemia. So some rare presentations of Wilm's tumor, they can have acquired van Willebrand's disease and present with a bleeding diathesis. And this is due to an acquired van Willebrand factor from the tumor, which disappears promptly once the tumor is being treated. Polycythemia is a very, very rare presentation. Weight loss, urinary tract infections, and most commonly constipation is one of the commonest presentations. And so many patients who come with a history of constipation or a bulge in the tummy are often diagnosed with constipation and sent away from the clinic. The differential diagnosis obviously includes hydronephrosis. So all these are benign disorders, polycystic kidneys, and really xanthogranulomatosis pyelonephritis. And then there are non-renal retroperitoneal masses, which include neuroblastoma and teratomas or germ cell tumors. So the examination is important. The weight, the height, and the mid-upper arm circumference should be done to assess for nutrition, and obviously a nutritional assessment should be done. The blood pressure should be done. You should look for signs of infection, tuberculosis or bilharzia or other, and I'll come to the reason why we should be looking for those, especially in Africa. We need to look for pedal edema to make sure that there's no inferior vena cava involvement, dysmorphic features, which includes hemihypertrophy and aniridia. So this is a picture of a child who's got a disproportionately large limb, or it may just manifest in the tongue. The abdominal mass needs to be assessed very well, and if the child is not able to relax or whatever, then sedation to examine the child's abdomen is permissible. So you need to find out where the child's mass is. Is it palpable, and is it ballotable? Because the renal mass occurs in the flank. It's a retroperitoneal organ, and it will distend the flank, that is between the rib cage and the spine at the back, which is called the flank, and there's usually a bulge there. And then obviously you need to measure the size, whether it crosses the midline, and whether you can get above it or not, and then the presence or absence of ascites. And then obviously a cardiac assessment, especially if there is inferior vena cava involvement. The basic laboratory investigations are not really very complicated or unusual. Obviously, you need to do a full blood count, kidney function, liver function with an LDH, iron studies and ferritin, and then a coagulation, which the screen should be done. And obviously, if the PTT is prolonged, the prothrombin time, then you need to actually do a von Willebrand factor if indicated, but you don't need to do that on all the patients. You need to do the baseline viral tests and blood grouping, and then urine dipstick for protein, blood, and glucose, and then to do urine catecholamines if you are unsure whether this might be a neuroblastoma or not. And so we wouldn't do a bone marrow because it doesn't spread to the bone marrow. So these are just the basic blood investigations. Then the radiological investigations are very important. Mandatory upfront is a chest X-ray to look for chest secondaries, and then an abdominal ultrasound, which looks at the mass, the consistency, the size, whether it's involving the whole kidney, to look at the other kidney and the liver and the inferior vena cava. So good ultrasound will actually give you all the information you need. However, when looking at the anatomy of the kidney, it's often useful to have other images of the mass. And many centers, especially overseas, are moving towards doing an MRI of the abdomen and pelvis, which is the preferred method of imaging if it's available, because there's less radiation. And then if you look at the DWI or ADC views, this may help distinguish the category of tumor or nephroblastoma versus Wilms. And this is an ongoing study that's happening at the moment, whether we can just look at doing an MRI. If you're going to do a CAT scan of the abdomen and pelvis, it's important to do a volumetric measurement to look and see whether there's inferior vena cava involvement, and then to look at the liver and other kidney, as the places of spread are the liver, the lymph nodes, the other kidney, the IVC, and those are the main ones. Then a CT chest is mandatory so that you can delineate small lung nodules. And then optional as indicated. So you might not know whether this is a nephro or neuro, and then you will want to do an MRBG scan to look for neuroblastoma, or you'll want to do a MAG3 scan if there's bilateral Wilms tumor. So this is just the umbrella protocol, which is the now the recommendations for treatments. And this just gives you a flow chart of what you should do before you do any kind of core needle biopsy or MIBG. And when you have definitive diagnosis, then you can proceed with treatment. Now, there have been two differences in treatment approach on either side of the Atlantic, and with the UK sitting firmly in the middle. And the first people to look at the, well, they well known, is the nephroblastoma Wilms tumor study group, which was really essentially in the North Americans. And the early studies stated that you should do immediate surgery to prevent rupture and to preserve vital staging. Then to say there's treatment according to stage, and there's treatment according to the histology. Whereas on the other side of the Atlantic in Europe, the International Society of Pediatric Oncology, which was started in France, and that one of the first studies that SIOP did and managed was to look at pre-operative or neoadjuvant chemotherapy. And they proved in the early days that giving pre-operative chemotherapy to shrink the tumor reduces the stage, and then the treatment is according to the tumor response. So it's a really in vitro test of chemosensitivity. And there were definitely fewer ruptures at surgery, because even if it hasn't ruptured up front, it might, the tumor might rupture at surgery. So there was an increasing use of response adapted therapy. So this is just an example of a Wilms tumor on the left, or my left, which is ruptured, and then obviously an intact tumor, which is obviously much easier to remove. Then from the 2000s onwards, there were progressively more trials looking at different risk factors, and the Children's Oncology Group took over the National Wilms Tumor Study Group. They combined all their study groups under one umbrella, which is called CHOC, or the Children's Oncology Group, and they looked at biomarkers as a measure of histology and prognosis. And then the Wilms tumor study group in CHOC went on to look at staging and treatment according to response of treatments. So these are the high-risk Wilm tumors. So on the American side, in the children's oncology group, you have the molecular. They do surgery up front, and then they send for molecular tests. And obviously, it's being one country, they can do it in a quick turnaround time. And then they looked at loss of heterozygosity of 1p and 16q, and these patients had a worse event-free survival. And also the gain of 1q also had a worse event-free survival. On the other side of the Atlantic in Europe, they gave some pre-operative chemotherapy, and then they looked at the histology and the response to the pre-operative chemotherapy. And they have diagnosed a high-risk Wilms tumor as a blastemal type, which is not to be confused with the favorable histology that is reported when the children haven't had surgery. And if you are remaining with blastemal tissue after you've had induction chemotherapy, then the chances are it won't go away. And therefore, that is actually an intrinsic resistance to chemotherapy and is denoted a high risk. And then obviously both groups, diffuse anaplasia, which is it's an unfavorable histology. And most of the patients have the TP53 mutation in these tumors, which has an adverse prognostic effect. So this is just a basic flow diagram of the treatment according to CHOC. So they look at if the tumor is less than 2/3 necrotic, and then it's divided into 4 types, and the high risk is the blastemal type, so it's only blastemal. The medium risk, intermediate risk, is epithelial, stromal, and mixed. And then we have the 100% necrosis, which is low risk. But this is quite a few little percentage of the cases. So, as I said before, the CHOC and the National Wilms Tumor Study Group, the first thing they did was to look at the stage, which was correlating very well with outcome. And so stage 1 is tumor limited to the kidney, but completely excised. Stage 2 is extending outside the kidney, but still completely excised. And then stage 3 has a whole lot of different criteria. There's residual tumor, there's invasion beyond the capsule, there's residual tumor in the renal bed, there's involved lymph nodes, there may be rupture or spillage. And this, and then you can look at for tumor seedlings on the peritoneal surfaces, especially if you've done a biopsy pre-treatment. Okay, then we have stage 4, which is distant hematogenous metastases, which is mainly to the lung and the liver. And they're usually circumscribed round lesions. And then we have a special stage in Wilms tumor, which is called stage 5, which is bilateral Wilms tumor at diagnosis. Okay, so bilateral Wilms tumor can either be synchronous or metachronous, which means it can occur at the same time or at a later time. But each kidney is staged according to that kidney. So just some notes on the staging when you have had pre-operative chemotherapy. In other words, there's slight amendments to the PSYOP staging. So if there's been response of the tumor in the renal sinus and or outside the capsule, but it's completely resected, it doesn't upstage the tumor. So the staging is always surgical. So you don't get a stage unless it's a stage 4. For the local kidney, the staging is always surgical. So according to what happened at surgery and then with the histology. Stage 2 is a tumor that infiltrates adjacent organs or the vena cava, but is completely resected and includes if you've done a biopsy through the flank. So not through the peritoneum, which will upstage it to stage 3. And then stage 3 is the presence of necrotic tumor in lymph nodes. So that always denotes a stage 3, where you can see that there was tumor in a lymph node, or it's present at the resection margin, or there's residual tumor in the abdomen. And any pre-chemotherapy open biopsy, surgical rupture, or piecemeal removal is regarded as a stage 3. And what is the significance of that, we'll talk about later, but it means the child has to have radiation, which is always a problem in children. So the principles of treatment, it's a very chemosensitive tumor. So chemotherapy is used to treat cancer cells throughout the body, and it affects fast dividing cells. Radiation therapy is important for local control and uses high energy X-rays to cancer cells in the specific area of the body. In Wilms tumor, the radiation is given to the site of the tumor in the abdomen and sometimes to the lung or liver. However, if the tumor has ruptured, or there is a pre-surgery open biopsy, or a biopsy through the peritoneal cavity, the tumor will be deemed to have spread or spilled, and therefore the whole abdominal cavity needs to be radiated. And obviously this is a problem because you need to shield the ovaries and also the other kidney. So surgery, and this is important part of treatment in nephroblastoma. And originally the Wilms tumors used to be in the hands of the surgeons first, and then only did the oncologists come later. But now we have a multidisciplinary approach, and every child is assessed together with the surgeons. But total nephrectomy is the key step in treatment and is essential for cure. So if your patient cannot get to surgery and have the tumor removed, it can never be cured. To be really effective, the surgery needs to be performed by either an experienced pediatric surgeon or an experienced general surgeon, especially in outlying regions where there may not be any pediatric surgeons, like in Africa. Laparoscopic surgery should not be done, as the whole abdomen needs to be explored, and you need to biopsy the things, and you can't put a huge big Wilms tumor into a bag to remove it because it will just spill the tumor. The approach should be through a large abdominal horizontal incision, not a lumbar incision. So you don't go through the retroperitoneum. And the kidney and the tumor should be excised widely en bloc, which means all together, with adjacent lymph nodes and peritoneal tissues. Then the inferior vena cava should also be looked at. This is just the pre-treatment that is used in SIAP trials. And basically, it's a response assessment of the volume, the histology, and the weight of the tumor. And it depends, it's 4 to 6 weeks, depending on whether they're metastases or not. And the mainstay drugs of treatment in Wilms tumor is vincristine, actinomycin D, and doxorubicin. So those are the three drugs, the most important drugs in Wilms tumor treatment. And these are widely available, and occasionally we don't get actinomycin D, but it is widely available through most of Africa as well. There is a new study group, which is the renal tumor study group, which is the CHOC renal tumor study group, and they've put out a what they call an umbrella protocol, which covers all aspects of Wilms tumor and non-Wilms tumor treatment recommendations, as well as having an arm where they will look at the molecular work in certain high-income countries, and whether this gain of 1Q or loss of 16P or 15Q will hold up as a poor prognostic factor. So the localized disease recommendations, if there is preoperative, you give preoperative vincristine and actinomycin D. You should do a nephrectomy upfront if the child is less than 6 months of age. And this is because this is the age where congenital mesoblastic nephroma usually occurs. A needle biopsy should be done if there's unusual presentations or you are not sure of the diagnosis. And then the histology after surgery, provides an in vivo chemosensitivity by histological subtype and volume reduction. And the aim is in the umbrella protocol is to improve the definition of the high-risk blastomal subtype, because this is really what confuses even pathologists and surgeons. And then obviously, if the tumor volume has not shrunk significantly with the pre-op chemotherapy, if it's greater than 500 milliliters, it's identified as a new higher risk subgroup, which will revert to having doxorubicin added to their chemotherapy. So this is the post-op recommendations, which I'm not going to go on, which I'm not going to dwell on, but in actual fact, you can see that all the stage 3s, except for the low risk, will receive radiation. And so that is a problem for long-term effects in children, as well as toxicity. This is just a brief evolution of the Children's Oncology Group, who started off as the National Wilms Tumor Study Group, and through all their trials over the years, they've gone for stage as being important, then stage and histology, then the age and the tumor weight. And in WTS5, they tried to not give any chemotherapy to children who were under the age of 2 and had a very small tumor. However, they had to abandon that arm of treatment because there was an excess of relapses in that group. And then the modern CHOC protocols are looking at the molecular characteristics of the Wilms tumor, and then the lung nodule response. And this is trying and avoid radiation in the lungs, for the lungs. And then obviously they've added it to their latest protocols as a risk factor. So what is the summary of the problem in South Africa? So we have 2 areas, and the first is the late presentation of our patients, especially the rural African patients. There are very large tumors that cross the midline, and for those people who have not been from the old days, it used to say that if a tumor crossed the midline, it wasn't a Wilms tumor, it was a neuroblastoma. Well, I mean, that's definitely not the case. That with surgery, there's an increased chance of rupture. There may be a lot of necrosis in the tumors with increased infection and morbidity, and sometimes hemorrhage into the tumors, malnutrition, and concomitant diseases. Or there is the normal presentation as in high-income countries. So we needed a strategy to have a safe but adequate treatment for large and late-presenting tumors, and to include the small tumors without compromise. So what are the lessons learned from PSYOP? As I said, the pre-op chemo definitely decreases the incidence of rupture at surgery. That 8 weeks pre-op chemo induces more volume decrease, though the stage distribution did not improve. That the pathological risk groups were more defined, and that stage 3 definitely had to have the addition of doxorubicin. From the German group, they looked at the volume of the tumor, and there was definitely a difference in survival between the large tumors post-chemo and the smaller ones. Although the epithelial and stromal subtypes may fail to shrink, but they have a favorable outcome. So they are excluded from getting the doxorubicin in that treatment group. So what is our South African approach? Is the majority of units in South Africa have a European CHOC approach, because more than half the tumors are extremely large, and most of them in the African patient are stage 3 and stage 4. And therefore, preoperative chemotherapy will benefit to decrease the size, downstage the tumor, and also improve the general condition of the child, the nutritional side, treat concomitant other problems, and get them into a better state for surgery. Obviously, this doesn't apply to children under the age of 6 to 11 months, and then all stage 4 and stage 5 bilateral tumors will receive the preoperative chemotherapy to assess response, and then to try and preserve renal function. So this was just a proposal where the PSYOP 4 weeks was given, then there was a surgery assessment, and if it was deemed to be not resectable or easily resectable, then a further 4 weeks of chemotherapy with the addition of doxorubicin for 1 dose was given. So Wilms tumor in Africa, we have some very unique features and common challenges, and this is all over Africa. So we have, as I've alluded to, late presentation, advanced disease, and a high tumor burden. You can see from these pictures, courtesy of Professor Larry Hadley in KwaZulu-Natal, that these are enormous bellies, okay, that should have long been diagnosed as Wilms tumor and not come at this stage. There's also associated severe malnutrition because the tumor is a perfect parasite, and there is loss of weight. So you can see how thin this child's arms are with virtually no fat or muscle tissue. There is a huge incidence of concomitant disease, HIV, especially in South Africa, tuberculosis, parasites like bilharzia, worms, and then of course malaria in the malaria belt of Africa. There's a lack of treatment center and doctors. So there's basically only 1 or 2 centers in each province. Some provinces don't even have an oncology treatment center like Mpumalanga and Northern Cape. There is a very long distance to travel from their little abode on the hillside And this often leads to treatment abandonment, especially if they can't afford to travel to the hospital. And this is where CHOC comes in. They have CHOC houses attached to most of the centers, and therefore they will, the parents will stay there for the duration of the treatment. But obviously this is a problem because they will, they leave behind maybe other families, maybe it's the breadwinner, maybe they, in the rest of Africa, they have to harvest their crop or do something at a specific time of year, and so, or plant their crops, and so they can't actually come for their child to treatment. And if they don't do what they're supposed, like planting their crops, then they will be you know, not have food or anything like that, or money. Then in some countries in Africa, there is a lack of chemotherapeutic drugs, and payment is required by the parents in some instances. There's also very little supportive care, so you have to be very careful about how you treat these patients, because they get very sick from having being malnourished. There's also a lot of African countries don't have radiation therapy, they don't have infrastructure, and they don't have laboratories, especially pathology. There's also a lack of experienced surgeons, and then there are cultural and belief systems, which is important in the African population. And you can see from this picture is the typical scarification marks around the umbilicus, and obviously the child presented with a swollen tummy. So in a low and income setting, so this was piloted in Malawi, Cameroon, and some of the very poorer African countries. We were looking to treat the Wilms tumors with a safe outcome in most of the patients. And so there was a minimum of tests that needed to be done, and the recommendations were made to decrease the dose of the chemotherapy if they were malnourished or under age of 2, and then they modified the protocol to allow for no radiation. But the risk assessment has been very difficult to do because of the paucity of pathologists in the rest of Africa. So in high-income countries, there are certain research modalities that are going forward and some challenges. So there needs to be a worldwide approach to the infant Wilms tumor that's actually under the age of 1 or 6 months, and adult Wilms tumor, which is very uncommon but does occur. The biology and application to risk and treatment, and then an innovation of radiation therapy approach to decrease the long-term sequelae, the standardization of radiological assessment of lung metastases, the standardization of lymph node sampling, and the guidelines for nephron-sparing surgery. And note, no laparoscopic surgery is mentioned here because it's not done for Wilms tumor. And then obviously the targeted therapy development for poor risk Wilms and non-Wilms tumor. And so the renal tumor study group in Europe and the children's oncology group in the USA have come together to have these approaches to these problems, which is called harmonica, and harmonization of these difficult to treat Wilms tumors. But they agree to disagree on the upfront treatment initially. And so these are my acknowledgements, and I'm happy to take any questions.
Thank you, Prof. there was a question for you. Should cardiac assessment be done in children prior starting of chemotherapy treatment for Wilms tumor?
Yes. So if the tumor is very large and you can't get a very accurate radiology assessment of the inferior vena cava, in some cases the tumor is a tumor thrombus that grows up the inferior vena cava through the lung and into the right atrium. It's also important, if you're going to use anthracyclines or doxorubicin, just to have an idea of the heart function up front before you even start. So in most cases you should do the function, but only in some cases do you need to assess for the tumor, the inferior vena cava tumor, going up to the right atrium.
Thank you, Prof. We didn't have any more questions. What came to mind to me, who is not a medical person, is the first sign of the Sincilio and early warning signs of childhood cancer on the high index of suspicion when it comes to the lump in the tummy.
Yeah.
And thank you for an excellent presentation. There's another, let me just see. Oh, it is just the person who asked the question to say thank you very much for the information. From our side also, Prof, we really appreciate your time and effort that went into the preparation of this presentation. Even I have learned a lot and can always just appreciate your experience and your knowledge and your professionalism. Thanks, Prof. So if there are not any more questions, if you need to refer a child, you are welcome to visit the CHOC website on www.choc.org.za. There is a refer a button, and then we will be hosting the CPD accredited webinars, as I said at the beginning. And the next webinar will be on the 4th of May, and Prof Gill will talk about osteogenic sarcoma. And then on the 25th of May, Dr. Jasmine Goga will speak on life-threatening blood disorders. So please tell everybody about these webinars and join in. They are for free. So thank you to everybody for joining us today. And please use the knowledge you gained today to go out and save lives. And I'm sure Prof Poole will be able to take any further questions should we get some on our chat line or through our Facebook. This webinar will also be available on YouTube if people want to watch it going forward. So thank you to everybody. Thank you to Wayne, our technical support. We always appreciate you. And thank you to Prof again. We truly appreciate you. Thank you, everybody.
It's a pleasure, and thank you for attending, everybody that attended.
Welcome. Thank you. Have a wonderful day. Bye-bye.